Hello, I am your host, Dr. Jack and welcome to the Medcastplus show. On the show, we will feature local community physicians who are experts in their respective field and who will share their experiences and wisdom with us. We cover a broad range of health topics on the show, and today we will discuss colon cancer. March is Colon Cancer Awareness Month and an important reminder for us to undergo colon cancer screening. Colon cancer is the third most common cancer, and unfortunately, over 50,000 people died of colon cancer in 2017. According to data from the National Cancer Institute, the risk of developing colon cancer is about 4 to 5%, and there are over 135,000 new cases diagnosed each year in America. With increased screening, the rates of colon cancer are declining in people over the age of 50, but new data suggests a rise in colon cancer in younger patients. 1 in 7 cases are now diagnosed in patients under the age of 50. There are ways of preventing colon cancer. First, it is important to have a conversation with your primary care physician or gastroenterologist to determine your risk factors. Average risk individuals should be screened at age 50, or if African American, the American College of Gastroenterology suggests beginning at age 45. One of the most common ways of screening, and the only way where you can find and remove precancerous cells, is with a colonoscopy. Precancerous cells accumulate to form polyps. These are small bumps or growths in the colon that can be removed during a colonoscopy. Preventing colon cancer with colonoscopy is important. Colonoscopy is painless when performed with intravenous sedation and takes about 15 minutes to complete. Here in Brooklyn at our colonoscopy center, we find precancerous polyps in about 30% of the patients we see. There are certain factors that would require someone to begin screening before the age of 45 or 50. These factors include a family history of colon cancer or advanced polyps, inflammatory bowel disease such as Crohn's or colitis, or other inherited genetic disorders. Today we have the honor of welcoming Dr. Hans Burkholder. He is a colon and rectal surgeon practicing here in Brooklyn. He is here today to discuss colon cancer and other related diseases of the colon and rectum. He treats patients with colon cancer in his practice, and he is a board-certified physician. He is board-certified in colon and rectal surgery and has advanced training. Prior to coming to Brooklyn, he completed medical school at NYU and moved on to practicing colorectal surgery and trauma surgery in Anchorage, Alaska. There he was the director of trauma surgery at Anchorage Regional Hospital. He is currently in faculty practice at Brookdale University Hospital and also operates at Methodist Hospital in Park Slope. Welcome, Dr. Burkholder. An honor to have you here on the show.
Thank you for bringing me.
Hans, Dr. Burkholder, we have worked together somewhat. We've had mutual patients, and I have to say thank you for providing world-class care here in Brooklyn for my patients. They love you, I love you, and I'm happy to have you here today to discuss colon cancer and some other diseases of the colon and rectum in which you specialize in. So as a gastroenterologist, I meet a patient, I do a colonoscopy for screening, I find a cancer, and we get a biopsy, we do a CAT scan, we do some blood work, and we determine that a patient needs surgery. And I tell them, here's a list of the doctors in Brooklyn. They end up in your office. What's the next step?
The next step is often just talking with the patient and helping them to work through some of their anxieties around the new diagnosis, because if the patient isn't able to cope with the emotions they have surrounding the diagnosis, they may delay treatment or not get things done as expeditiously as they should. So the first step is making sure the patient understands what the diagnosis is and what the treatment options are.
So the first meeting you have with them, you sit down sort of as we are today with a desk. There's no procedures that day.
Exactly. The first step is to gather all the information, make sure that the cancer has had the appropriate staging workup so that we know exactly what stage the cancer is, so that we can develop the best treatment plan for that patient. And that often involves, more doctors than just me. It often involves an oncologist, a gastroenterologist like yourself. So there's usually a whole team of doctors that are making decisions together about the treatment plan and workup for these patients.
And that's true today for nearly all cancers. It's a team approach. There is the primary care doctor who has to help us all make sure the patient is safe to undergo surgery. In colon cancer, we find them as gastroenterologists most of the time. We refer them to you as well as to a oncologist, which is a cancer doctor. These are the folks who give chemotherapies, or what we call radiation oncologists who give radiation therapies. And so we put the team together, they meet with you in the office, and let's take a hypothetical patient who is early stage. Can they go directly to surgery and to cure?
So once the medical doctor has cleared them for surgery, a lot of times surgery is the next step for that patient. And I always enjoy treating those patients because their chance for cure with surgery is very, very high. And so it's good news for those people when we do all the CT scans, the blood work, and we find that our chance for a cure with surgery is going to be in the high 90s. So that's always very good news.
Right, and you mentioned that statistic, which is a very, very important statistic, and it shows how well we have done with this disease, is that from the National Cancer Institute, the 5-year survival for a patient diagnosed with early colon cancer, meaning they met us somewhere early in their disease. I did a colonoscopy, we found an early cancer. Their survival at 5 years is 90% or better in most cases. That's incredible.
It's amazing with the advances in surgical and medical care, how a disease that used to have a much higher mortality we're able to treat once it's found, but also with appropriate screening, prevent from happening. And colon cancer is not happening as often as it used to, thank goodness.
Right, the preventative measures for colon cancer, the most important is to simply get checked, to undergo screening for colon cancer, which in my practice as a gastroenterologist, colonoscopy is the most common way that we're screening for this. That's a test where I take a little camera and we look through the colon while the patient's sleeping. It takes about 15 minutes. And it's done at the age of 50, sometimes earlier for certain patient populations. We start at a younger age. I find polyps and remove them, and because we as gastroenterologists are finding these polyps early when they are a precancerous condition, we're actually taking away some business from the colorectal surgeons because less and less patients over the age of 50 are getting colon cancer.
And I would love if you guys would make me obsolete.
We would love to make you obsolete too, because if you did not have business, that means we were successful.
Exactly.
That means we found the polyps, and even sometimes polyps that have a little small cancer in them, I can cure them during a colonoscopy by removing the polyp, and then they just need to be watched without surgery, which is fascinating. But the problem I see is we have a higher or a rising rate of cancer in young patients. And that brings me to my next question. When I meet a patient who has rectal bleeding, meaning they go to the bathroom and they poop or move their bowels, however you want to say it, and they see some blood. Now, in my practice, I see that in all ages, young patients, middle-aged, older folks. What's your approach to patients who have blood per rectum, blood when they move their bowels?
So my approach with them is to do a complete history and physical exam and see if I can see on physical exam what may be causing the bleeding. And most patients who come to my office with bleeding do not have colon or rectal cancer, but that's always in the back of our mind as something to be concerned about. So we'll look for things like hemorrhoids, anal fistulas, anal fissures. Those are all things that can cause bleeding and are not cancerous conditions, but those patients need to come in and be checked. And I have patients who come in telling me they have hemorrhoids that are bleeding and they've been ignoring them, and I look and they're not hemorrhoids, so it could be a cancer.
Right. And that is an important thing today with the rising rate of colon cancer in folks under the age of 50. We know 1 in 7 of these cancers are going to be in someone under 50, so they will have not yet undergone a colonoscopy for screening. So someone comes into my office with rectal bleeding. I've had cases of young men, young women who have been told by other folks, whether they're medical professionals or even looking on the internet, that it's hemorrhoids and not to worry, when in fact, we always do colonoscopy or sigmoidoscopy, some investigation. And I have found cancers in 30-year-olds and 20-year-olds. I have found polyps in young people. And we have to all be aware that bleeding is always abnormal no matter where we think it is coming from. And so if I go ahead and I do a colonoscopy on a patient and I find this tumor, a cancer, they end up in your operating room. How do you remove the tumor? What techniques are you using today?
So in most cases, we're able to use minimally invasive techniques, which can be laparoscopic or robotic, and remove a lot of these cancers with those minimally invasive techniques. And that's important for the patients because they have a lot less pain with surgery. The recovery process, they recover a lot more quickly and just overall get back to feeling themselves a lot faster than what people did decades ago with the more traditional surgical methods.
Is a laparotomy, correct?
Correct.
And that is the scar or the line that we all know of from TV shows or
Right.
from seeing folks on the beach sometimes, which is a scar from the bottom of the chest down to the belly button. That's a laparotomy scar.
Right.
Now, I've sent you patients and other colon and rectal surgery patients, and they have seen other surgeons too, where they come into my office, they have had a colon cancer removed, and I can barely tell.
Yeah, in some patients, if the scars are placed in the right place, they're cosmetically very hard to see. And so some patients have a very good cosmetic result.
And not only for cosmetic reasons, but for recovery. They're able to get out of bed quicker, they're able to go home quicker. Is that true?
That's true. And in addition to the advances in minimally invasive surgery, there's new advanced enhanced recovery protocols that are speeding up the time that people can get out of the hospital, have bowel function, start eating. There's less nausea with these enhanced recovery protocols, and so patients are doing much better with some of these new.
And this enhanced recovery really means that as soon as you're done sewing up the last cut in the operating room, recovery begins almost as they're being wheeled out the door.
Right, and it really has taken the treatment focus off of just doing the surgery to how we treat patients both before the surgery in terms of what we give them to eat, how we do the bowel prep, but also after the surgery, how we manage their pain, how aggressive we are about getting them walking as quickly as possible. And a lot of these non-surgery adjuncts are really getting people better faster, and we've found they have a lot less discomfort, a lot less nausea, and the surgery is much easier for them to go through